Hello, I'm Mallie Shansfeld, Managing Editor of Implant Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. August de Oliveira. In our webinar today, we will be discussing the evolution of implant connections. Before we get started, I would like to invite viewers to use the chat box on the right side of your screen to ask any questions, and your questions will be answered at the end of the session. Also associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees the presentation replay along with instructions on how to access the CE quiz. Now I'm pleased to introduce our guest for today. Dr. August de Oliveira graduated from dental school in 1997 and from the University of Washington and completed his general practice residency in Los Angeles in 1998. Dr. de Oliveira has been lecturing on 3D technology since 2004, when he started as a CEREC basic trainer. Since 2008, he's been involved with Implant Direct's R&D department, developing guided surgery software and hardware, and testing their CAD milled bars and substructure department. He has written 3 books on dentistry: Implants Made Easy, Dental 3D Printing Made Easy, and Guided Implantology Made Easy. He's been involved with beta testing Sirona's Sodexis program, as well as developing the Opti and CEREC milled surgical guides. Dr. de Oliveira is on the board of directors of Sprintway, and beta and alpha tests numerous 3D printers and 3D printing software. He has completed over 100 digital hybrid arches and teaches digital and analog restorative at Implant Pathway on live patients. He also teaches for Implant Direct, Ivoclar Patterson, Henry Schein, and holds his 3D printing parties worldwide. Dr. de Oliveira is a certified Unity VR and AR software developer and is currently developing virtual reality simulations in dentistry and mixed reality 3D diagnostic tools for the Microsoft HoloLens. Dr. de Oliveira, we turn the webinar over to you to learn more about our topic for today.
All right. Hey, thank you so much. Hey, everyone. Let me just get this going here and let me know if you can see the slide. Molly, can you give me confirmation? I think that's a yes. Someone give me a shout out. Unfortunately, I don't have the chat
I can see the slide.
You can see the slide. Yes. Great. I don't have the chat box available on my Mac for some strange reason. Usually when I do a webinar, I kind of like to watch the chat to make sure that I'm not losing anybody or someone has an immediate question. But unfortunately, I can't see it. So type your questions in the chat box. And at the end, I'll go ahead and answer everyone's questions, hopefully if we have time. So thank you for tuning in. It's in the afternoon here in the West Coast. I'm sure it's a little bit later on the East Coast or wherever in the world you are right now. So we're going to be talking about implant connections. And, you know, it's interesting. I gave the same webinar maybe about 5-6 years ago, right when sort of conical connections were becoming used more. And now it seems that, you know, there's much more data, there's much more information about changing to different types of connections. So I'll be speaking about that, speaking about restorative, speaking about tie bases, and different things that have come out new since my first webinar. So great introduction. I'm not going to talk about myself anymore. Interesting enough, when Implant Direct asked me to do this webinar way back, I thought, well, it's kind of not in my wheelhouse. I'm kind of Implant Direct's resident nerd. I teach 3D printing and guided surgery and digital hybrids for Implant Direct. So what can I talk about for a whole hour on implant connections? Well, whether you're a digital dentist or an analog dentist, it really doesn't matter when it comes to connections. Our goal is the same. We want to develop restorations that look great, that are self-cleansable, and will retain bone around the implant for a very long time. Hopefully forever, but in dentistry really can't stay forever. But we want them to stick around. So before I get going, and I don't want to butcher his last name, But I got to tell you, most of the inspiration for this lecture came from the zero bone loss concepts. And if you've taken the course or have the book or have seen Dr. say Linkvexius, anyway, Dr. Thomas' zero bone loss concepts course, it is eye-opening. And it's interesting because when he did all the research for it, he went through his cases, which are, I'm going to say, much nicer than mine, and found cases that retain bone and cases that lost bone. And I got to tell you, it's very humbling to go through your stuff and see your own bone loss, and it's kind of painful. But as you progress and as implantology progresses, you know that you've got to change techniques as we go. So you're going to see a lot of my failures in this course. I hope you don't think that I'm a hack, but we all try to do what's best for our patients with the research we have at the time. And so hopefully I can add to Dr. Thomas's lecture and show you some of my own cases and where applying the right information about implant connections can really help keep your implants healthy. So when I started and I did this lecture 5 years ago, I thought to myself, how am I going to talk for a whole hour about implant connections? I mean, it's either like a trilobe or a multi-unit. It's either got a Morse taper or a conical connection or a hex. But really, when we choose an internal connection, why do we change from the status quo? Well, in reality, this lecture is going to be about bacteria. To be honest with you, we want implant connections that are going to stay put, to avoid screw loosening and breakage, that avoid loose crowns, and prohibit the ingress of bacteria into that implant connection and the resultant inflammation that occurs that causes bone loss and causes tissue inflammation and just overall bad stuff around our implants. So before we get going, I want to make sure we're all on the same page. And it's interesting, when I started placing implants back in 2008, platform shifting it was kind of a new concept back then. And I think now, as we look at most new implant designs, platform shifting is the norm. So if you don't know about what platform shifting is, what platform shifting simply is that an implant is wider than the internal connection and the resultant implant abutment. So if we think about it, we want room for bone to hopefully grow over the top of the implant, or at least stay put at the implant platform and give us some room for our biologic connection of the tissue. So interesting enough, when I finished my residency back in 1998, I went out into the real world. And I remember as an associate, being an associate in office, and if you are an implant associate or have been an implant associate, it's pretty normal to just do like pedos and prophies and maybe the occasional filling. We really don't get to do a lot of restorative when you're fresh out of school. And so I remember a patient came in and needed a bridge. And I prepped that really nice, double packed the cord, got a great impression, felt really proud about it. And then I went away for the weekend and I came back on Monday and I saw the patient back on my schedule and it said re-prep bridge. And the owner doctor came out and said, August, you prepped these teeth all wrong. You're too close to where the gingiva is. Let me show you how it's done. And so he went ahead and took a thin needle coarse diamond, shoved it in the bone, stepped on the rheostat, and started prepping my beautiful preps all the way down to the bone. And he said, that's how you do it. You want to hide that margin as close as you can to the bone. And, you're going to do a PFM, so you don't want them to see that margin. Well, what happens when you place a margin next to the bone? Bad things happen. So if we look at the image in the upper right, you can see that there's definitely a biologic width invasion, right? So those PFMs are way under the patient's gum line. Her gums are swollen and yucky, and it's just not a good situation. So if you think about it, if you look at the image on your left, you're going to see a tooth side and an implant side. And the tooth side has those horizontal blue streaks, which are called Sharpie's fibers. And Sharpie's fibers just basically take the good attached tissue and connect it to the cementum of the tooth. So we need room for that attachment, and we need room for a little bit of a pocket, and that's where we get good response to the biologic width. Now with implants, we don't have Sharpie's fibers. Sharpie's fibers can't connect the attached gingiva to the implant surface. So we get around that by two ways. One, we want a lot of good attached tissue to kind of form a collar around our restoration. And two, we want that implant connection to be down towards the bone. If you look on the image on the right, and although that abutment post is really super skinny on an ankylosed implant, look at how nicely the bone attaches to that. And you can really see an exaggerated platform shift that allows that bone to grow not only to the top of the implant platform, but over it. I mean, that is the goal, right? That the body loves your implant so much that it wants to grow bone over the top of it. So, interesting enough, if you look back on your failures, maybe you don't have failures and you're so awesome, but I have failures. And if I look at probably, let's say, 90% of my implant failures, I'm going to say that they're related to either having a very thin biotype or just no attached tissue around the collar of the implant. So because we don't have Sharpie's fibers, that tissue is movable and can pack food. So Dr. Thomas looked at different biotypes and how the bone retains around the implant. A thick biotype is a no-brainer, right? There's just a ton of good attached tissue. Pretty much as long as you stick your implant in bone, it's going to stick around. But Dr. Thomas went back and really kind of blew my mind. So we know that we want a band of attached tissue between 3 to 4 millimeters on the buccal and palatal. Kind of implant 101. But what he did was he looked at the vertical. He looked at the tissue height from the bone platform to the crest of the gingiva. So we're talking about this dimension, right? And up and down. And he said you need a pocket of at least 3 to 4 millimeters of attached tissue around your implant for that tissue to form basically a turtleneck around your implant and attach that tissue. And I got to tell you, once I learned that, I've changed the way I do dentistry. I make sure my implant is low enough and there's enough attached tissue for me to not only have that 4 millimeter band, but to have depth, to have that pocket. And I know pocket is the wrong word and sounds bad, is something we need. So how do you get good attached tissue? Well, obviously a free gingival graft is kind of the gold standard. I got to tell you, I'm not great at those. And so I refer those out to my periodontist. But what I do all the time are apically positioned flaps or laterally positioned flaps. Basically, we know that if we lay a flap, we've got to make some sort of a crestal incision, right? And usually we do it on the center of the crest. Well, why not make that crestal incision a little further onto the palatal and take 2 vertical releases and move that tissue to the buccal and apically. And so you can see in this example here that on the image on your lower left, the patient has no attached tissue on the fascia, 0. The unattached tissue comes all the way to the crest of the ridge. So I knew I had to lay a flap anyway. So I went ahead and made my incision on the palatal side, put 2 releases, and just rolled that tissue forward like a rug. And then I used anatomic healing abutments. These are called Contour Healer, and you can purchase them at contourhealer.com or Pearson, Patterson, or Shine. They all sell them. And so I propped that flap up. And you can see on the image on the lower right, we do have more attached tissue on the facial than where we started. And we have that 3 to 4 millimeters of depth of gingiva. So implant anatomy, I'm not going to spend a lot of time on that. We all know this stuff. But our implant platform is the top of the implant. And per the platform shift, the implant platform is going to be smaller than the width of our implant. Doesn't really matter which body you use. I do a lot of immediate implants, so I prefer a implant that has aggressive threads. The implant collar is very, very important and goes hand in hand with that internal connection. So the implant collar, if I had my way, would be blasted or coated all the way to the top of the implant. So I don't want any shininess around the collar. And we'll talk about implants that do have polished collars. Surface treatments, I'm not going to get into details here. It's kind of out of the scope. But we do want something with a high surface area to really interact with it. And apices really don't apply to this, but if you want an answer, I prefer a blunt apex on my implants. I don't want them deviating from where I'm drilling. Sharp apices tend to allow you to reposition the implant, which I guess could be cool, especially in immediates, but in general, I do a lot of my stuff guided. I've already spent time to make that hole, and I want my implant to go on the hole. So we have 3 kind of zones to manage, right? We have the bone, we have the tissue, and we have that restorative connection. So if you want an implant that is just never going to loosen up, that's probably going to have great bone all the way around it, use a TissueLevel implant. Now, I don't. And the reason why is they're ugly. So if you look at the picture on your right, tooth number 8, the right central incisor, is made on a TissueLevel implant. And that is just ugly. And the reason why it's ugly is the emergence profile starts basically at the crest of the gingiva. So these TissueLevel implants remove the bone abutment interface. So they remove the implant connection from the bone and put it supracrestal. So you're not going to have any problems with loose abutments or loose screws. However, the trade-off is you have less control over your final restorative. Some implants have polished collars. I know that was cool back in the day. To be honest with you, I just don't like polished collars for 2 reasons. One, if you put a polished collar subosseous, you're going to have no bone growth around the polished collar. Second, if you place a polished collar at the level of the gingiva, if you have any recession, you're going to see it. It's cool in the posterior, but in the anterior, it's not cool. So I don't use those. I think most people use a bone level implant. I place my implants 1 to 2 millimeters subcrestal, and the image on the lower right shows a bone level implant on tooth number 9 with a Cirrus crown. So that seems to be the mostly accepted terminology, but there's other ones out there. So interesting enough, there was a push. I don't know if it's still going on, but maybe about 3-4 years ago from a couple of different implant manufacturers that said, okay, here's the deal. We give up. We're going to have bone loss. It's going to be down to like the first or second thread, and we're just throwing in the towel. So we're going to make the top of our implant shiny, like the first third of our implant, and expect bone loss. I got to be honest with you. I don't subscribe to that field of view. I think we should have no bone loss. Just like Dr. Tomas, zero bone loss, right? I don't think these got too popular because I don't really see them used in the US. Maybe they're not used anywhere in the world anymore, but I don't like this philosophy. Just make it shiny, you're going to have bone loss. The fact that it's shiny supposedly is less irritating to the gums. But again, I don't think that's a good way to go. Interesting enough, implants that have a polish collar, that have a transgingival portion, so tissue-level implants, have made a bit of a comeback. And interesting enough, where they're used is typically around sinuses. So if you think about it, we're in D4 bone, right? So it's just spongy, yucky bone. And there's a tendency, even with our internal sinus lifts, to accidentally perf the sinus floor. Now, I've been here. This is not my case, but I have lost an implant up in the sinus and got it out by doing a sinus lift. But by using a tissue level implant in this region, that basically, even if the bone is spongy, that transmucosal portion is wider than the body of the implant and will keep you from going back in there. So interesting enough, this is an old, I couldn't find any new data, but back in 2015, Glidewell Dental Labs looked at all of their types of implant cases coming in. And they noticed that a 268% increase away from standard non-conical connections into conical or a tapered internal hex. And we'll talk about that. I call it LeadinBevel. So most dentists got the memo that we want to go with some type of conical connection. So back in the day, when I first started placing implants, the Nobel replaced Trilobe was a very popular implant. And I just restored one today that a patient had in his mouth from about maybe 20 years ago. And I got to tell you, a Trilobe implant is probably the easiest implant to place and restore. That internal connection has a trilobe. It only goes in 3 ways, right? So if you're putting your abutment on that, you only have 2 other ways to screw it up and 1 way to get it right. So why don't we all use flat on flat or trilobe connections? And I'll explain what a flat on flat is in a little bit. Well, one drawback of the Nobel replace was that it was not a platform shift implant. So the abutment and the internal connection, or the implant platform, was the same width as the implant. And so if we had screw loosening, which we did a lot, or screw breakage, which we did a lot, that movement would agitate the gums. So we don't use those really anymore. We kind of do. There's certain implants that still use that trilobe connection. Back in the day, Dr. Gerald Nisnik invented the LeadinBevel design. Back before Dr. Nisnik, most people were using external hex type implants. So Dr. Nisnik developed this. It became used in all Zimmer implants and the Implant Direct legacy. So this is a tried and true design consisting of a hex. So we have basically 6 different ways for the implant to go in, and something called a LeadinBevel. And I'll get more into details about a LeadinBevel. But basically, this is a mini conical connection. So if you look to the purple implant, basically we have a flat top, and the implant and the abutment rest on top of that flat top. If you look at the LeadinBevel design, what happens is we have a hex, and then we have a little taper. So we've got a little bit of ferrule between the abutment and the implant internal connection to resist lateral movement. Now, conical connections are kind of all the rage now. Popular in the Nobel Active, the interactive implant, Straumann bone level implant, Astra, all these different implants use a conical connection. So what a conical connection is just a really deep internal connection with very minimal taper. So what that provides is a longer distance, a longer ferrule to resist lateral forces. So when the patient's chewing side to side, that implant has walls that bolster the sides of it. Now let's take a look at the thicknesses of these 3 internal connections. Now, if we look at the Trilobe design, one common problem that we found with Trilobe type implants was where those triangles are, look at how thin the implant is. So these types of implants were more prone to breakage than our implants of today. The thickest one is the LeadinBevel, the internal hex design. And you can see just a lot of titanium around those flats of the hex. Now, as we go to the conical connection, look at how thin that is compared to the hex. It's better than the Trilobe, but it is thinner. And so the only implants I've seen breaking are very, very thin, very long conical connections and Trilobes. I've never seen a internal hex break, but hey, probably will happen next week. And so let's take a look at that ferrule that I was talking about. And this is shown in the orange arrows. So on a flat on flat connection, we have no internal ferrule, right? It's just the implant screws in. There's really no sort of bolstering effect of the implant itself towards lateral movement. We can see a smaller amount of ferrule in the LeadinBevel in the internal hex, and you can just see a giant amount in the conical connection. So if we look at these videos, these were done by Dr. Ziprich, and they call them the Ziprich studies. And if we look at the implant on the left, and I believe this is an ankylosed implant, you can see here that as that implant is being pushed laterally, there is no wiggling going on. Now let's take a look at the right. And so this is a flat on flat connection. And take a look at the right. You see the little opening that we get in the movement, the micro movement of the abutment in the implant itself. That's bad, right? So Dr. Ziprich talked about a micro gap and micro movement. And so the micro gap is that space that's opening up. And what he said, he had a great analogy. And Dr. Ziprich said, well, when you were a little kid, do you remember like it raining and you put on water boots and you go jumping around in the puddles and, you know, you jump into one that you think is shallow but super deep and you plunge in and those boots just suck in the water, right? So that's what's going on in this lateral movement. There's this pocket opening up between the abutment and the implant, and that is just forcing saliva into the internal connection of the implant. And if you've ever unscrewed basically an old abutment on a flat on flat, it is stinky. And so it's stinky because of that lateral movement. Now, with bacteria making a little home inside of your abutment, what's going to happen? Well, we're going to get tissue inflammation and we're going to get bone loss, right? Because there's also no platform shifting, any bone that's in contact with that area is going bye-bye. So we want to make sure that we take advantage of using some sort of connection that has internal ferrule. So I'm going to talk about something that's not an internal connection, but it's very, very connected, for lack of a better word, to it. And that's using a tie base. And so if you're not familiar with what a tie base is, a titanium base or tie base is like a mini abutment where we put something on top. And that what's on top could be a screw-retained crown, like in the image in the middle. Or we could make an abutment, or we could do something crazy and do something called a screw-mentable restoration. And what a screw-mentable restoration is kind of the best of all worlds. It's a custom abutment, so it doesn't really rely entirely on the tie base, and a crown with a hole in it. It's basically cemented in the mouth, unscrewed and cleaned, and cemented back on. And I'll talk about all three of these types of restorations. So one thing about tie bases is when tie bases first came out, I got to tell you, the design was terrible. And the reason why it was terrible is twofold. One, that connection between the tie base and the restoration, or the tie base and the ceramic portion, is 0.5 millimeters away from the bone. And so because it's that close to the bone, then we're going to have biologic width issues that we try as hard as we can to polish the cemented restoration that's on the tie base, but we don't really get it all off, or maybe it's a little rough, and that's going to cause problems down the line. Two, it's the wrong color, right? It is gray. And so one thing that I'm really impressed with the evolution of tie bases is that tie bases, and what you're seeing here is the Implant Direct Smart Base. People kind of stepped aside and said, okay, look, this is a dumb design. And so we've got to design it different. And so tie bases now have variable heights. So if we have a very subosseous implant, we can select between 0.5 up to about 2 millimeters of heights. They come in different colors. So in this case here, the Implant Direct Smart Base, the gold portion is what's contained within the ceramic, and the pink portion is your transmucosal portion, or what goes from the implant to the top of the ceramic. We'll be talking about concave versus convex emergence profiles. Spoiler alert, concave is the way to go. And I know that doesn't make a lot of sense, right? We've always been taught, hey, we want to build out that emergence profile to make it look just like a tube. But I think studies have shown that having a concave gingival profile or a concave bone profile will further that platform shifting and give us room for our biologic width. So let's talk about old school tie bases, right? So this guy came in, tooth broken off, really no ferrule. So we decided we're going to do an immediate implant. So took the tooth out, put an implant in. And when it came time to restore it, we used at the time, this is a Dentsply Sirona tie base for the tapered screw bent implant. Now you can see there on the bottom that we have a very short tie base, and that connection is going to be really close to the bone. And in this case, this was a SubCrestal implant. That connection is actually at the level of the bone. Just a pet peeve, if you just want to ask me, I don't like third-party screws on tie bases. And back in the day, a lot of implant manufacturers would not hold up their warranty if you used someone else's screw. And I want an OEM screw. I want a screw that's designed for my implant. And so if you look on the image on the bottom on the right, you'll see a little wimpy, itty bitty tie base screw. And on the left, you'll see a very nice thick screw. And so that is the screw that was designed to go with the implant. So we put the implant in, or the implant crown. This is a screw retained crown. And at the time of delivery, you can see that implant is very subosseous. And if you look down the line at this implant, it's subtle. It's not terrible. But look at the mesial of the lower right radiograph. And you can see that I'm having some vertical bone loss down to the first or second thread of the implant. I believe that a lot of it has to do with the tie base design. So it's 0.5 millimeters. It is at the level of the bone, and it is a convex gingival profile, right? So it is wider than the diameter of my implant, ignoring all what we've learned about platform shifting. Contrast it to another one. So this is a case patient I did an immediate implant on. We placed a contour healer and started shaping the patient's gingiva. We have a thick biotype, and we were also 3 to 4 millimeters below the gingiva. So we designed, in this case here, a screw retained crown. I milled this in my dental office with a type of mill called a VHF Z4. Take a look at that beautiful tie base. And so that tie base is a 2 millimeter collar tie base, and it is concave. So the interface between the Emax restoration and the tie base is 2 millimeters above the implant platform. Now let's take a look. So basically we milled it out in the VHF Z4. We cemented this tie base as an Implant Direct 2 millimeter collar tie base. You can see here we've sealed up the screw. This was at the time of scanning, and this is probably about 2 or 3 years later. Now take a look at that image on the lower right. So this is an internal hex, so kind of a mini conical connection. And look at the bone around that tie base collar. And so our bone has actually grown into the concavity of the tie base. And that is like the holy grail, right? We want so much bone, and we want the body to love it so much that it actually grows over the top of the implant. I said my piece about wimpy tie base screws. One thing you also have to know, if you use a third-party tie base screw, they will have their own sort of amount of torque to tighten it. And so a standard Implant Direct screw usually gets about 30 Newton centimeters of torque. And you can see here it's 30. But in some cases, that is going to deviate. And one thing I don't like about these wimpy tie base screws is the size or depth of the screw head. So look at that little wimpy screw on the left and look at the screw on the right. And so our insertion tools have so much more to grab onto with a longer head of the screw than those wimpy little itty bitty tie base screws. So when we talk about internal connections and micro movement, what is the worst thing that can happen? And that's so much movement that we end up breaking the screw. So I don't know why this screw broke, but it did. And, you know, it's so funny. You go online and you talk to dentists at meetings, and they're like, oh, yeah, you know, we just put a little ultrasonic in there and it pops right out. Have you ever tried that on a really torqued down screw? If the screw is loosened, yeah, if you put an ultrasonic in it, the screw is going to unscrew. But if you have something that's torqued down to 30 Newton centimeters and breaks, it's really hard to get out. So there's lots of tools out there to remove broken screws. So in this case here, I basically screwed into what was left of the screw. And I got to tell you, Astra and Zive probably have the coolest broken screw kits. What it basically is like guided surgery. You have this sleeve that goes in. You literally drill the screw out and re-thread the implant. It sounds really kind of horrible, but it actually works. So in this case here, we just unscrewed the screw. We were able to replace it. In this case here, we used an OEM screw, the original screw of the implant, and got it in there. Okay, so let's talk about the emergence angle. And so what we basically want is we want a concave emergence profile. And one drawback of using stock abutments is that most stock abutments come in 0.5 millimeters. So like our tie base, their margin is close to the bone. So to develop emergence profile, we basically have to start really low and build it out. And so I love custom abutments. And custom abutments, you can have a concave profile, and you can set that tooth abutment interface far away from the bone. But don't get too crazy. So look at this example here. I've got a very built out crown on a tie base. This is a 0.5 millimeter collar on a tie base. And the lab did a good job. They really just tried to mimic the width of the tooth root. However, it provided too much pressure on the bone. And look at the resultant bone loss. What do you do, right? So there's no pus, there's no inflammation around this tooth. So we're just observing it, but it's certainly not ideal. So what we want is a very narrow emergence. And so if you look at the crown on the right, in this case here, this is a screw-retained zirconia crown, you can see that that emergence profile is underdeveloped. And as a result, we've retained bone around the implant. Another area that we can have bone loss is when we put on our healing abutments. And so most healing abutments are wider than the implant that they're on. And they do that on purpose because we want to start shaping the tissue and get the tissue looking more like the tissue around a tooth instead of around an implant. I would venture to say, though, that if you could, try to use a concave collar on a healing abutment. And so what that's going to do is allow that bone and that good tissue to have biologic width and stick around. Another thing that a concave profile can give you is if you're planning your implant and placed your implant SubCrestal, which I place my implants 2 millimeters SubCrestal. And I know people are going to say, whoa, that is too much. Very cool studies that have been done. Dr. Sheldon Katz did a very interesting study and basically said, hey, look, you're placing an implant, right? And it's got a platform shift. So if I place that implant supracrestal, will I get bone crawling up the side and going on the top of the implant? No, right? So if I place that implant at the crest, will the bone grow over the top? No. If I place that implant below the level of the bone, do I have a chance of the bone growing over the top? Yeah. Also remember that trabecular bone is different than cortical bone, right? Trabecular bone has a lot of blood supply. And with that blood supply comes our osteoclast and osteoblast. Cortical bone is basically avascular bone. And so if I place my implant platform at the cortical crest of the ridge, am I going to get a lot of good stuff happening? Am I going to get osteoblasts and osteoclasts around there? Probably not, right? But if I place that in vascular bone, I've got a better chance. So, you know, different companies, Implant Direct in this example, has a separate concave collar. You can use that. or you can buy healing abutments with a concave collar. One thing I do is that after the implant is healed, I like to start to shape my tissue. In the posterior, I use these contour healers. And you can see in my example there, I've got that nice 3 to 4 millimeters of depth of nice attached tissue around my implant. But now I can start to shape that. And that makes it so much easier when I deliver my restorations. Now, in the anterior, I would rather just do an abutment and a crown. But in the posterior, I want to sort of shape these up. Another thing to note, think about where your lab or you is placing the margin between the abutment and the crown, right? So one really cool thing about Emax is my go-to material for screw retain crowns. I gotta be honest with you, I don't use it a lot for abutments just because it's too translucent. But one thing you can do with Emax is you can actually put that crown implant connection supragingival. And what that will do is get rid of any problems you could have with bone loss due to cement sepsis. Now, you pretty much only want to do that if you have a very thick restoration. And what I just found with Emax personally is if I had a thin restoration, that gray tie base is going to show through. So now I've switched to using titanium or zirconia. But you can see here in this example, on the lower right, I used a titanium abutment. It's in the posterior, so it doesn't really matter if you're at the crest of the gingiva. So in this case, I am equigingival in my titanium abutment. Another thing you want to be mindful of when you're using a tie base is that tie bases tend to be very short. And just like general dentistry, if we have a short, a tooth with not a lot of ferrule, we worry about that crown rocking, right? So same example when it comes to tie bases. So if you have a choice of using a longer tie base or using a custom abutment, that's going to keep your ceramic restoration from loosening up around your implant. And so if you want to just go crazy, belts and suspenders cover all your inadequacies of tie bases. Don't use a tie base. You can actually use a custom abutment. So this is a case that I did. And this was a patient who had limited opening. And I got to tell you, my implants aren't very parallel. And so you can see the implant in number 18 is convergent on my implant on number 19. So what I want to do is, in the posterior, I try my best to do screw retain crowns. But if I have the situation where two crowns have to draw together, you would basically have to make all the crowns sideways to get this to screw in. So a different type of restoration is called a scrementable restoration. Some people know what that is, some people don't. But in a nutshell, it's basically a custom abutment with a crown with a hole in it. What you do is you place the titanium abutments on the implant, hand tighten them, don't torque them down. Put these crowns with a hole in it with cement them down. Then you're going to unscrew them and clean them up. So check out this radiograph here. So this was immediately after cementing. And I thought, okay, look, I don't see any cement around those restorations. But look at the image on the upper left. There is a ton of cement around there. So, there's cases where I've had bone loss. I take a bite wing. I don't see any cement. I don't feel any cement, but there is cement. So with a scrementable situation, you cement the crowns to the titanium abutments in the mouth, unscrew them, and then clean them up. So you may ask yourself, how is that different than a screw retain crown? Well, because there's a lot of spacer between the titanium abutment and the crown, we have the ability to kind of jiggle them down. And so we can get around contact points. We have a longer chimney. So basically we have a greater amount of ferrule in this situation. And that's all I have for you. So thank you for listening. It looks like I'm a little bit early, so we can go ahead and spend some time on some questions. If you have any questions regarding this, look up Digital Enamel. That's my website. It's on Facebook, or you can email me directly at augustdds@gmail.com. So I'm going to go ahead and stop the screen share.
Okay. Thank you, Dr. de Oliveira. There are some questions coming in, but before I get to those, I would like to again invite viewers to use your chat box on the right side of your screen to ask any questions you have, and I will ask them for you. We have a question. Why do some implant manufacturers not platform shift on some of their sizes? For example, the Legacy 2, 5.7/5.7. Oh, I think we just lost Doctor. He'll be signing back in. Give us a minute. I cannot hear you. Excuse us, folks, for the technical difficulties. Doctor, we seem to have lost your feed. Why don't you sign in again? Here he comes.
Okay,
Thanks.
sorry about that. I hit leave instead of stop share.
So
did
you hear the question?
Yeah, I heard the question. So okay. Why is the Legacy 5.7 not platform shipped? Good question. I wish I had Dr. Nisnik here to answer it for me. But I believe it's because the width of the implant is 5.7 and the connection is 5.7. So there's literally nowhere to go smaller. Now, could they have designed the 5.7 with a 4.5 internal connection? Yeah, but that would be pretty confusing. So that's the reason why the 5.7 doesn't have a platform shift. Now, newer implants, why are they not platform shifted? I haven't really heard of anyone that has a new. Oops, I'm getting an echo here. Oh, you know, listen. Let's see. Speaker.
I'm not hearing an echo.
I turned my speakers off. Can you hear me?
Yes.
Okay, I still have the echo. It's going to be fine. Okay. Do we have any other questions?
Yes. Oh, okay. Yes. There was a comment from Dr. Tang. I just restored a Trilobe, also not my own. Patient broke the abutment crown, so he needs a new crown. That was just a little message to you. And then there's a question: when screwmentating, any risk of locking the crown beneath a proximal contact and not being able to get it off? For example, if the path of withdrawal of the crown is different than that of the implant?
Yeah, that's. I think that the spacer with the crown and the abutment would sort of help you out. But yeah, that's definitely. It's never happened to me. Give me time. I'll probably.
Okay. Next question: can I use Implant Direct tie bases with my CEREC machine?
No. So Direct's in office milling only works with the dense place tie base. So it's made that way. So the tie bases it blocks the hole. And implant tie bases don't fit those blocks. So now you can scan and Implant Direct and export it as SPL, or you can set it within Direct software to an exo. But no,
Okay, I'm getting a little echo now too, but my next question is, how do you prefer to use custom abutments or tie-base supported abutments or screw retained restorations? What do you prefer to use? Custom abutments or tie-based supported abutments or screw-retained restorations?
That's a great question. Sorry about the echo again. For the most part, I like to use screw restorations in the posterior. In the anterior, I let where the screw is dictate. So if the implant is too facial, I'm going to have to use an abutment and bring it
in. If conical connections are considered better, why do you still use LeadinBevel connections?
Oh God, that's great. You know, so if you look at the Bevel replacement, that's easiest abutment to put in. It just goes right in. And if you look at conical connection, because it has that paper, you really have to check an X-ray to see if that's down all the way. So a leading is kind of the best of both worlds. So it's got that it's, but it's not so deep, and it doesn't have the taper that it prohibits your income down or your down.
Okay. How do you deal with bone loss that is not catastrophic around an implant?
Great question. I evaluate the situation. I look at, do I have inflammation around the patient in pain? Do we have, pus around there? If nothing's going on, we have bone loss. If the patient has, then we ask ourselves, out easily. Take the pen out easily, out. Then I graft it. If we can't, and try to graft, we can clean the implant surface with citric acid. In general, I find it hard to add bone to the situation, so I'd rather.
Okay, one more question. We're really having a lot of trouble with that echo, but one more question before we have to close. Do you prefer? Can you
turn that off? Let me go to settings, internal speaker. It doesn't allow. Actually, you know what I can do is mute. I won't be able to hear it.
Okay.
Can you prefer, just let me know? Just in the chat.
Yeah, I can hear you. How do you prefer? Do you prefer zirconia screw retained restorations or Emax screw retained restorations?
Oh, okay. Well, we're gonna have to just live with the X. So let me turn off mute. Okay, I'll try not to talk.
Okay, last question. Do you prefer zirconia screw retained restorations or Emax screw retained restorations?
I think Emax is pretty. So zirconia is going to be stronger, but let's face it, we have huge restoration, and even if Emax is not going to break. So I would use Emax, better looking.
Okay. I'm sorry for if we had some technical difficulties. We've run out of time for today, but we thank everybody for your questions. And if we did not get to your question, we will answer it after the webinar via email. Shortly, we will send you a link to the replay of this presentation and instructions on how to access the CE quiz. Be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Again, thank you all for attending. A special thank you to Dr. August de Oliveira and our sponsor for this webinar, Implant Direct. Thank you and have a great day.
Thanks, everybody.